Hi, everyone. My name is David Macklin. I am a family physician. I have been practicing obesity medicine as a medical director of multidisciplinary teams since 2003. I also come to you today as a co-author of the Canadian Clinical Practice Guidelines for the Treatment of Obesity. I was a co-author on the behavioral and psychology chapter. Behavioral therapy is one component or pillar of obesity treatment. Obesity treatment has three pillars: behavioral therapy, medication, and surgery. Most people understand what medication and surgery are, but very few understand what behavioral therapy is. If that's something you're interested in learning about today, you are in the right place. Today, we'll be learning about the module called wanting. Wanting is the fifth of 8 modules in a knowledge translation of the behavioral chapter. The objectives of today's talks are: first, over about 8 minutes, you will learn what wanting is. Then, over 6 minutes, you'll learn that addressing wanting is the central effective reason that the 3 pillars of obesity management are effective. And then finally, over about 10 minutes, you'll learn how to address wanting with your patients using the now well-known ALCIE method to learn effective and simple and practical methods of addressing wanting in your patient population. Let's get started. We've talked about how the fundamental understanding of why obesity exists is because of a collision between our modern food environment, an obesogenic food environment filled with ultra-processed and ultra-portioned and ultra-available foods, that collides with our ancient appetite system, an appetite system built for when calories could be scarce and work was required to find food. And this collision results in extra calorie intake beyond homeostatic need. But what exactly is the mechanism? And that's what we're going to be talking about today. So this story starts with the work of Kent Berridge, who I think someday might even win a Nobel Prize for his work on liking and wanting and the mesolimbic appetite system, the motivational system, the hedonic system. Goes by all these names. And he described early on, and this is a 2009 paper, the concept of incentive sensitization and salience. And I invite everyone to not overthink the concepts of incentive sensitization and salience, because this is really Pavlov's story. The idea is that it was discovered that repeated exposures to what are rewarding foods are foods that our brain considers to be evolutionarily important, and it values and prizes the calories that are dense in energy and dense in taste. And so repeated exposures to foods of reward value in susceptible individuals, because we've of course spoken about how obesity is a genetically conferred real medical condition, and there is variability in genetic vulnerability to this exact process that we're talking about now. But these repeated exposures in susceptible individuals can persistently change brain circuitry that regulates wanting, the motivational drive to calories. And these changes are suggested to lead to high levels of wanting associated to the foods or the associated cues. Meaning that if cues get paired enough times with, again, abundant or tasty or dense calorie experiences, a learning takes place, which is called Pavlovian learning, or it's called associative learning, or it's called incentive sensitization or salience. Building on this, Berthoud, in this 2017 paper, Blaming the Brain for Obesity, talks about the expansion from traditional homeostatic understandings of the regulation of appetite and calorie intake to include hedonic controls of appetite, the hedonic system that interacts with the homeostatic system. And really, it's hard to speak about them as separate, and they control together and regulate body weight. And of course, we describe how this association, these two homeostatic and hedonic or motivational systems, how these two systems and the neural processing contained within is really outside of awareness. And it is very difficult to cognitively, from the top down, in a world of plenty, restrain against these subconscious circuitries or neural processes that drive and motivate us to calorie intake. Here's a paper by Ruth Lewes and Gilles Yale. Here, using genome-wide association studies, it's discovered that there are, in this case, almost 1,200 genes. And stay tuned because the number might land at 9,000 different alleles, all of either major or minor contribution to the risk of obesity. Stay tuned because the giant consortium of data combined with a 23andMe database may soon come out to describe 9,000 genes, individual genes, as predictive of BMI. And so here within the paper, it's described that genes are either enriched or square. Are these genes enriched? Exclusively expressed within the brain and the CNS. And these all have a central role in obesity. And key to this point today about wanting is that the hedonic pathways, the major drivers of body weight for both monogenic and polygenic obesity, are key contributors where genes are expressed from these genome-wide association studies. Again, landing at 1,200, maybe even 9,000 sometime soon. Here, Eric Stice, in the neurovulnerability factors for obesity 2019 study, using neuroimaging to suggest that individuals at risk for obesity show a hyper-responsive element in their reward circuitry, higher levels of wanting to high-calorie food tastes. And this supports the incentive sensitization model. Overconsumption of high-calorie foods results in an increased reward and attention region responsivity. This is the conditioning we talked about. And eventually, these drives and motivations are towards high-calorie foods via a conditioning process. Here, a meta-analysis of 22 brain activation imaging studies that describes that those with obesity exhibit, again, hyper-responsivity of the brain regions involved in taste and reward for food-related stimuli. Again, when we say reward, we're talking about the motivational subconscious drive centers of the human brain. And again, well supporting the incentive sensitization model. And what about hunger? We keep talking about wanting. Here's a really interesting Dixon 2015 study, ghrelin signaling on food reward, that describes that, what about ghrelin? Ghrelin leads to hunger, doesn't it? You might be surprised to learn that ghrelin signaling at the level of the mesolimbic system, where the reward system, where the motivation system, where wanting is generated from, is one of the key molecular substrates that provides a physiological signal connecting the gut and reward pathways. When levels of ghrelin are very high, this is resulting in activation within the reward system. If we're hungry, we're wanting food. We don't dissociate hunger and wanting. You can certainly have wanting where there is no physiological need for calories and no hunger. That happens all the time. But if someone is also gone too long without food, or even within a time of their day, a time span that literally raises ghrelin levels, we know at the highest ghrelin levels, we have higher activation of the reward pathways, and wanting is stronger. The the mesolimbic system, the nucleus accumbens, this dopamine pathway appears to be a key target for the ghrelin system. And a primary role for ghrelin is to regulate rewarding aspects of eating, wanting. Again, the key subject of this module. So what happens if we apply these principles clinically? Well, here, behavioral therapy, medical therapy, and surgical therapy serve as the pillars of obesity management. And here an example in behavioral therapy, where Evan Foreman, the acceptance-based group, here, the acceptance-based versus standard behavioral treatment, clinical trial, Mind Your Health, randomized controlled trial. Here, standard behavioral therapy is compared to acceptance-based therapy. And one of the key differences between these two therapies is in the acceptance group therapy, there's a significant focus on the adherence to healthy eating goals and its dependence on the ability to self-regulate in the face of biological predispositions, the drive to consume high-calorie food, and the pervasive cues that facilitate overeating. In other words, the focus of one of the key skills within acceptance-based and clinical-based therapy, difference from standard behavior therapy, is a focus on wanting, on helping individuals identify wanting and understand when it's happening and its nature, and the potential destigmatizing message that comes with explaining wanting to a patient. And of course, we have spoken about this earlier, by adding both a focus on wanting and also values-based behaviors, and also what is called metacognitive awareness, three additions in acceptance-based therapy to standard behavioral therapy, we see better outcomes at 1 year. We see a 13% mean weight loss in the group compared to the standard behavioral therapy 9% group. And they were compared head to head in a randomized control trial. And this was published in 2016. What about medications? The control of eating questionnaire is a very well validated questionnaire that describes a measurement of the drives and motivations to foods, and a conditioning in theory that is taking place through someone's lifetime, and their cravings, in this case they're called, but also can be a synonym for wanting. And here was a clinical trial in 2021 where a double-blinded parallel group trial, 72 adults with obesity, randomized to semaglutide once weekly or placebo for 20 weeks. And here the control of eating questionnaire clearly indicated better controls for of eating, fewer weaker food cravings, weaker cravings with the semaglutide group versus placebo. So we're starting to see how by focusing on wanting in a behavioral therapy, but also in a medical therapy, how these can be the central components of what creates success and outcomes treatment of those living with obesity. Here are some key clinical and research findings that simply support the concept that by targeting GLP-1 receptors and the effective GLP-1 receptors, not just in the homeostatic system, but in the reward system where wanting is housed. Here's a paper from 2016 that showed for the first time demonstrating GLP-1 receptors in human brains. They also observed that liraglutide alters brain activity related to highly desirable food cues. The levels of liraglutide were shown to reduce food cue responsiveness in the brain. Here's a paper from Blumendahl in 2015 that showed that GLP-1 receptor activation decreases the anticipation of food reward, which can reduce cravings for food and that increase otherwise consuming food reward, which may prevent overeating. Here again, a signal that there may be an activation of GLP-1 that can reduce the wanting component and not just the hunger component, which is formerly what was thought to be the effect of activating GLP-1 receptors. Here, GLP-1 can regulate food reward behavior by acting directly on the hindbrain. This is the nucleus solitary tract. And so here we have GLP-1 receptors, and this reveals that food reward suppressing roles are available if the GLP-1 receptors in the NPS are activated. And we now think of this as one of the key sites where reward, drive, motivation, wanting is reduced, again, through GLP-1 receptor activation. Here results showed support for the idea that mesolimbic GLP-1 receptors are sufficient to reduce this hunger-driven feeding, the hedonic value of food, and the food motivation. Here, this paper describes in 2013, again, a neuroscience paper, again demonstrating GLP-1 receptor activation and the association between that and decreased reward and decreased motivation and decreased wanting. What about surgery? Here, a really interesting 2020 review paper that addressed Roux-en-Y gastric bypass surgery, and the conclusion that the surgery, what is the appetite effect? What are the key appetite effects of RYGB? Here, RYGB has an inhibitory effect on the mesolimbic dopaminergic pathways and the response to visual and smell cues to palatable, calorie-dense foods. And again, the point they notice is that this is GLP-1 receptor signaling that is a consequence of the bypass surgery, and the effect is decreased mesolimbic wanting. And so we accumulate all this evidence that the actions, the mechanisms of action of behavioral therapy, medical and surgical therapy, seem to be aimed at diminishing the subject of today's module, which is wanting, or the motivational drive to calories. So what does this all mean clinically? How will this change my practice? What will I do differently? So as you all know, when we talk about the clinical application of any one of these models. We talk about clinically applying this in a conversation format that focuses on the ALCIE method: ask, listen, summarize, inform, invite. And so when patients are describing to us in our clinic, face to face, their concept of what they're experiencing in regards to appetite, we listen. We might hear the following. We might hear someone suggest that their behaviors are because of, this is their interpretation, not necessarily, or in fact, quite not necessarily, what actually is motivating and driving their appetite. Their confabulation or interpretation is that they're doing it to feel better, or everyone else is, or maybe I'm sabotaging myself, or I think I'm a stress eater, or maybe I'm an emotional eater, or it must be because I'm bored, or I think it helps me relax, or it can help me calm down, or I'm looking for a boost in energy, or I'm doing it because it's a reward, or I tell myself I have room. These are the interpretations. And so when we hear them, of course, the next step after listening is summarizing. And so what you're telling me is that you feel these eating events that you're describing are to feel better, or because others are, or because you're feeling it might be you sabotaging yourself and you think you're a stress eater. LMNOP. Is that correct? Yes, that's correct. Exactly, the patient says. And of course, the last step then becomes the inform invite. This is where we scratch our head and lean in and say, I'm wondering if you would consider the science around weight management has changed, where we understand now that wanting is the prime central motivation to food, something called wanting, which runs in subconscious circuitry in our brain. And this is the main driver of over-consuming calories and overweight and obesity. It's a consequence of an ancient brain built for a time when calories were scarce or work was required to collect calories. The collision between that ancient brain and our modern obesogenic food environment. It's an incredibly genetically heritable trait. So there are really key differences between people based on genetics. And the mechanism is this Pavlovian or associative learning mechanism. Would you consider that over your life, certain cues and settings and times and places have been paired with foods, abundant food, high calorie food, taste-dense foods. And this association repeatedly has resulted over time such that the cues themselves now generate wanting. And so the homework we would leave with patients is to help them discover, with our help or on their own, what are their high-risk times, what are the cues that over time have become associated repeatedly with dense calorie or high-taste foods, and the associative learning has taken place. Because managing these high-risk times and settings is considered to be the central skill in weight management. Being able to manage these moments of wanting through behavioral therapy or medical or surgical therapy is, we would argue, the key predictor of outcomes and success in both weight management and in health benefits. Of course, as always, we provide a script, and you can kind of learn the words on your own over time. This will all be included in the materials that are available to you. And if we have time, in our inform invite, we can, if time permits, you see on the right side, we do this exercise with our patients. And how we do the exercise of helping them discover their high risk times, the times where they're subject to wanting, goes something like this. I'd like to ask a question about your eating patterns. Eating healthily and being active are critical behaviors, but not the focus of today's conversation, and certainly not strong predictors of success in weight management, yet this is. And so we talk about weight management, we talk about eating behaviors, we talk about patterns. So the question would be about your eating patterns and what we might call high risk times. If you look at your day as a timeline from when you wake until you go to sleep, I'm wondering if you find that there are any places and times and settings within that timeline within which you would just on average find yourself to be at higher risk of higher calorie intake or less controlled eating. Are there any settings and times and places that stand out? A significant portion of patients will describe and be able to share, some immediately, the details of this conditioning without being completely aware that this was the process that led to these behaviors. So classically, we will ask the setting, the time, and the place. Well, when would this be? And a patient might say 9 to 10 p.m. There I'll be in the family room or in my on the couch, and is there anyone around? They would say, no, I'm by myself, and what are you doing at that time? I'm watching TV or on my computer doing some emails. And then the key question that speaks to this last question, how many times has this happened, speaks to the Pavlovian associative learning. That's quite key. So when we think we have a setting and time and place that might be a place and setting and time where a patient's subject to wanting, one key last question is how many times has this happened? Because there is this necessary associative learning will have taken place. So the question would be you, evening, watching TV, couch, relaxing, unwinding, end of day, post-dinner, pre-sleep. How many times do you think in your life has that setting or a setting very similar to it been paired or associated with tasty food or abundant food or high calorie food experiences? And the patient will often say thousands. I never really thought about it that way, but I guess it even goes back to my childhood or starting in adulthood, thousands and most nights perhaps. And these associations they start to understand have led to a incentive sensitization or motivation or associative learning, which results now in the cues themselves gaining the power to generate the central mechanism of what drives excess calorie intake, even without biological need, even rather without energy need, which we call wanting. So we then capture the time and the place and the setting, and we invite the patient to consider that again, this key time and place and setting, managing this may be an absolute key predictor of their success long term. And we're simply meeting with them at the end of this module a very straightforward exercise for homework, which is for them to just notice this. That's it. Would you consider going back out and in these times stop, maybe take 2 or 3 minutes, not necessarily change your behavior at all? That's not the stage we're at. Just simply notice, oh, is this what Dr. Macklin was talking about? Is this what my doctor or nurse or dietitian was talking about? How this setting, and they can look at their watch and say, oh, right, couch, TV, end of day, 9:30, 10 o'clock, no one around. And what does this feel like? How strong is it? Where do they feel it in their body? Can they give a name to it? And then finally, the last piece of homework would be to consider a destigmatizing opportunity. So wait, so you're saying that this is a neurological reflexive event that happens in a subconscious circuitry in my brain, in a system that was born genetically vulnerable to having this learning be stronger, and through associations throughout my entire life, it now has resulted in the settings themselves driving this strong motivation, again, from a subconscious source that's difficult to self-regulate against. And yes, that's an entirely destigmatizing message to a patient that they're subject to wanting. And so we leave them finally the homework to consider accepting that this is what they face. This is the central neurological event that leads to them struggling with weight, and it can be managed with behavioral therapy, medical therapy, surgical therapy. But now the homework is just to notice it and consider even accepting that this is what they experience. And that's the wanting module. Thank you very much for all the materials will be available to you. Really, the exercises at the end of delineating the high risk times with your patients is the exercise in the practice that you can build over time, and then leaving the homework of noticing and accepting that our patients are subject to wanting. Thank you for your attention.